There we go.
Hello, everyone, and welcome. I want to thank you for joining us today for the first week and the kickoff of Dr. Arneson's psychiatric tapering course. I am Dr. Kareem Kandil, Medical Director of Naturopathic Doctor News and Reviews Journal of Applied Natural Medicine. And today we are fortunate to have Dr. David Arneson join with Dr. Daniel Nola to kick off this first lecture. Dr. Arneson has over 25 years of experience as a naturopathic physician with a focus on addiction treatment, and also has developed over the past 25 years his framework for psychiatric tapering. As has been mentioned multiple times before, psychiatric tapering is a very important field in medicine. Many clinicians are trained in how to prescribe a lot of these psychiatric medications, but when it comes to offering support and deprescribing, this is an area where there is, often a lot of missing information. And today, our hope is to introduce everyone to Dr. Arneson's approach and methodology for dealing with psychiatric patients, with the kickoff and focus on motivational interviewing. So, with that, I turn it over to Dr. Dave Arneson.
Thank you. All right, get this up. Okay, first of all, thank you all for being here. And this first lecture is sort of my experience on how to identify and to treat different kinds of people. And I think what's important about this first lecture, more than anything, is that willingness to communicate, to find out what kind of a person that we're actually treating, what's the condition, what created it, depression, anxiety, or symptoms. And there's always something that lies behind that, whether it's genetics, biochemistry, perceptions, situations, and so forth and so on. Not everybody fits under the bell curve, that's for sure. Um, so that's part of my history there. Just, I started late. I went back to college at 38. I was a contractor before. Went to the University of Texas at El Paso. I have a double major in biology and psychology, and graduated from Southwest College for Naturopathic Medicine in August of 2000. I was then 46 years old. Um, on the side, when I was going through medical school, I worked for Southwest Behavioral Health and Crisis Stabilization. So um, I actually worked with a lot of seriously mentally ill people as a plebe, I mean, I was just one underling. I had to interview these people a couple times a day, write a SOAP, and give that to the psychiatrist, and they'd work with it. I also have a personal experience with a schizophrenic uncle and a number of my family members that were in addiction and so forth. So 25 years of plus primary focus on treating drug and alcohol and mental health issues. And I've been a founder and a co-founder of 3 different naturopathic inpatient detoxes, which is almost unheard of. I don't know, there might be some more out there I'm not familiar with, recovery programs, and the River Source, which closed down, I think, about a year ago, but I was involved with them up till 2001. One of the things that pushed us was whatever was happening out there wasn't working. I mean, we would see uh, patients that might be addicted to something that chronic relapses, stuck in post-acute withdrawal. And then I was very fortunate in my first naturopathic detox in 2000, 2002, basically people off the street. They had no money, no insurance, and we begged and did whatever we could to get supplements in and to try to correct diet. But of course, they had food cards, and they go down and get Mountain Dew Red and Twinkies and everything else. And then finally figured out they're off the street, at least they're eating. And that's where we really started looking at how can we make a difference, or is there something inherently wrong with mentally ill people, or something inherently wrong with alcoholics and drug addicts, which by nature in standard medicine, they are going to get some kind of diagnosis, which is bipolar, et cetera, et cetera, et cetera. Next. And nothing is more important than a good history. Now, I'm going to tell you, I think most of us that have been docking for a while, we become kind of positive skeptics after a while because are we getting the stuff that we need to get so that we can treat efficiently and safely, and to come to understand what we're treating, not just emotionally, psychologically, what we're treating biochemically, physiologically, and so forth. Um, to understand the underlying cause of all dependencies, whether addictive or not, because we can develop a dependency on these antidepressants, and certainly with benzodiazepines. Uh, and we're going to cover that in a lot more depth in this next lecture next week. Um, and then to understand the role of codependency in mental health issues. And we'll have some stories about that too. How to successfully communicate with the patient via motivational interviewing. And I just tell you, and I'll tell you, I've been teaching clinical medicine for 24 years, 23 and a half. And unfortunately, I wear hearing aids. So I learned really quick if I was going to get anything out of the patient, they had to put the pen down and face them face to face and communicate. It's unfortunate in our standard medicine regime that we're forced to see people for 5, 7 minutes, whatever, and come to some place where we can treat them effectively and so forth. And we push them off into sort of the dark hole because the patients will come to you and say, well, doctor never said it would do this or do that or whatever. And even though on occasion I do write antidepressants because nothing else works, so you're going to find out that there's sort of a 5-10% rule. 5% of the people who walk in, it's going to be the easiest thing you ever did, and 5% of the people you treat, you'll never have an answer. 10% of the people, you're really going to struggle. 10% of the people is not too bad. And there's that 80% in the middle. And then we talk about the bell curve and two standard deviations on either side. Going to talk about genetics and how genetics plays a role, epigenetics, and so forth and so on. Next slide. And then just to understand some degree about medical management, because medical management of addiction or medical management of depression is generally going to be drugs, drugs, drugs. There'll be some degree of pushing people off into counseling and other types of programs, and that's fine. But one of the things is we seem to have a branch of medicine that treats the physical and a branch of medicine that treats the psychological. Then we have a branch of medicine, well, not medicine per se, but the spiritual aspect of the human being, that sense of, what human beings crave more than anything is a sense of purpose and meaning in your life comes out of the spiritual arena, and the spiritual arena is not about religion. Spiritual arena is about reaching your potential and doing something, especially something like service to others, which you guys will understand out there. I'm assuming most of you are doctors. And then understand the roles of tools that are available for these people, 12-step programs, counseling, nutritional medicine, spiritual tools, how to utilize nutritional medicine as basics of treatment. Then that's going to be protocols and stuff that we developed from 2000 on, because the idea really is, what if this case could be pretty easy? We have patients that have come in here on $1,500 worth of supplements a month and never found the answer. And that one lady, she said, "What do I do?" And I said, "I don't know, but what I'm going to do is I'm going to start over." And she said, "Well, I can't do that." And I said, "Well, I can't treat you because what am I going to add to that? What am I going to take away from you?" It's just almost impossible when we start on that, start treating, and we see the case as complex when we actually should see the case, okay, what if the simple works? Because if I start the simple, basically, I can work my way into the complexity of each case. But if I start at the complex, it's almost impossible sometimes to move back to the simple. So the ethical treatment of the patient is paramount. Patient comes first, not our egos. We're working with the whole body, the whole patient, not just the drug, body, mind, spirit. So then, these are kind of the things I learned in med school, and I had to put those in practice. Know what you're treating. If you don't know what you're treating, then step back, or, when you guys will have my email address and so forth. And if you got cases you want to discuss, send me an email, we'll discuss it. I'm hearing impaired. Most of the time, my phone and my Bluetooth work. I don't do accents well when I'm talking on the phone, and I can give it more thought or consistency if I'm doing email streams. Don't overwhelm them with therapy. Give it time to work. Um, those are the three lessons I took out of med school that have been my stay to course of action for 25 years. How long does it take to step down on any mind-altering drug? It has a lot to do with the half-life of that drug, how it's metabolized, and so forth and so on. Not every person fits into the average half-life. You have slow metabolizers, you have fast metabolizers, and you can usually get that out of the history. Well, I could, I did it once a day, but that didn't work. It worked better if it was twice a day, and so forth and so on. Put down the pen, get away from the computer, eyeball to eyeball, and learn to hear with your eyes as well as your ears. It's one of the things that we do when we sit down and do these kind of things and sit there and face the patient, because we're going to hear through body language and so forth and so on. We'll hear so much with our eyes. Probably half the information I get is that eyeball to eyeball process. And when the patient here really, because there was a study some time ago, 75% of the people left the standard medical office. Their major complaint was the doctor never heard a word I said. We don't have to be that. If we're going to do this work, if we're going to be successful at it, and we won't be successful in every case, believe me, we build that system of trust with that patient, then they're willing to follow the suggestions. And like I tell them, I said, if it doesn't work, you can always go back on the antidepressant. I mean, that's nothing, right? So with that trust, the patient will, they'll follow your suggestions and be more compliant with therapy. So that's important to take a good history, but one cannot always take that as the whole truth. So the next slide is kind of a case study that happened to me. Sue C was a well-known local artist in the area. Son died 2 years prior, went into depression, unresolved grief. She treated with Zoloft for depression, subsequently on Xanax to control the side effects of the SSRI. Insomnia occurred and then put on low dose of Seroquel. I think I can't remember, it was 5 milligrams, I think. Seroquel for sleep. All the above information given by the patient who came in would seem to have logical cognitive function. Talked to her one-to-one. Her husband came in, sat in the room, every clinic visit, but never offered any other information. Somewhere around a year or so, a year and a half, we had her off all her medications, never had any doubt she was a functional patient. Tended to treat her over another year or so for various common ailments. One day she showed up with a terry cloth bathrobe knotted around her chest, and I said, "What is going on?" She says, "Well, my heart is so heavy."
Oh,
He
sorry, we
said,
got kicked
"Go
out.
ahead. We got a blip."
Yeah.
Go figure. What up? What's right there? Um, I can't read that.
1 second. Can you guys still see the slides?
Sorry about that. Hello, everybody.
Oh,
No, not the
well,
slide.
yeah, you might just have to reshare that again.
Okay.
All right.
Sorry
Okay, I
about
think
that.
it's
That's
coming.
what I got. That's what I got.
You good?
Anyway, and then he said, well, she gets like that, you know. Asked him what was going on. He said, "Oh, she gets that way when there's some overwhelming event in her life, and she's been hospitalized several times for psychiatric care in her life. The overwhelming event, her daughter got married. Resolution, transported to a local psychiatric hospital for stabilization and care, where she was inpatient for about 45 days. I did have a quiet question and answer session with the psychiatrist. Unfortunately, this is how we learn sometimes. History, 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 but always have some thought as how accurate that history is. And I will say this as a add-on, majority of the cases that you're going to treat aren't going to be these kinds of cases, but you have to be aware that it's very possible. Uh, that what you're getting is not the truth. Generally speaking, had I known that this had happened, I would have referred her back to her psychiatrist and then had a talk with the psychiatrist and made a decision whether I wanted to actually handle the case or not. I probably would have, but only with some communication between me and the psychiatrist. Next. And so when we start talking about actually um, treating somebody, the first question you always ask is, do you have any idea of why you're depressed or, why you're anxious or so forth and so on. Depression and anxiety are connected to each other with an umbilical cord, and very often depression can happen as an adjunct to anxiety and so forth and so on. From my clinical experience, a full 85% know exactly why they're depressed. Generally situational, perceptual issues, trauma issues, and so forth and so on. And there are those patients that need serious counseling. So what we do is I always have 2 or 3 counselors that I just make a phone call to, depending on what we're working psychologically with, to get him in some level of counseling while we're doing the work. And then so that would be a good thing to find out who's counseling, what kind of counselors you have in your area, especially those that deal with trauma. Same goes with unresolved grief. And this is going to be a big one. Almost all the ones that, especially the older ones that may have lost a husband or wife, that come in that had to be strong for the family. And then I'll give you some ideas and some concepts how I handle that. Patients on multiple medication, you really need a drug interaction study done, and you can just go online, druginteractions.com or whatever, list the medications, find out, if you have enhancers or so forth and so on. Multiple medications, hypertensive meds, so forth and so on, that go through different pathways in the cytochrome 450 pathways. Sometimes there's major interactions there. And those major interactions there, they can be part of the symptom picture that they might attach to the medication they're on. Well, in fact, if we can take a look at that, one of the things, we had a patient not too long ago was on Cymbalta, and she'd gotten off Cymbalta, and then she had a major crisis. Then she got back on Cymbalta, and which goes through 3A4. Cytochrome 450. And then she called and said, I don't know what's going on. My blood pressure's off the charts. And this medicine kind of worked for me before. I didn't like it. I got off of it and found out that she'd started drinking grapefruit juice, which is an inhibitor to 3A4. So she was detoxing, or not detoxing, but having reaction because she was keeping too much of that Cymbalta in her system. So they act as substrate enhancers or inhibitors. Very, very easy. It's a little bit of extra work, but once again, maybe a smaller percentage of these people that have this issue, what's the average half-life of the medication? How's this half-life can vary between patients via genetics, diet, or nutritional aspects, but also through epigenetics. So as the computer is one thing, the computers is something that was programmed at birth, but it doesn't mean, like any computer, it needs input to have something come out of it, smell of food, taste of food, so forth and on, for it to become active. And so anything basically that can affect that, the computer's always trying to bring it back to some sense of normalcy, or it adapts to that situation. And the longer they're on the med, especially with things like antidepressants, things like benzodiazepines, the more it kind of gets stuck there. And we'll talk some more about that in one of our future lectures. We'll talk a lot more about the CYP 450 pathways in the next lecture we're going to give you. And nothing ingested by the patient works on a single physiological function. Nothing works in a vacuum. Affect one system the other systems are affected, sometimes positively, sometimes negatively, sometimes in a minor way, and sometimes in a major way, which seems really complicated in many ways. Okay, where do we start? Well, we'll get to that. But the first thing is to kind of define um, what we're working with and how to approach that individual on their own personal pathway to get the best, I would say the safest and the best process to work with them and what we want to do and how we want to react to things like continued depression and so forth and so on. So the common statement for patients on antidepressants, just flatlined me emotionally. It was okay at first. I didn't have to deal with anything. Almost all I want to feel again. And that's the key after a year or two on antidepressants. And no joy in your life, no libido, so forth and so on. They want that back. So a lot of them come in, and of course they're anxious and they don't know what to expect. But we just take it nice and gentle. We'll talk a little bit about what it takes to do it, but in the protocols that we've set up, generally we can have somebody off an antidepressant in about 6 to 8 weeks, generally about 6 weeks, depending on half-life and so forth and so on. And then you have to know that some antidepressants do have addictive properties. One of the things I wanted to bring in is just this is actually a lecture I give on addiction, but it also is appropriate for this lecture tonight. So John Carter was a very good friend of mine. He was 45, 46 years sober when he passed away, 43 years as a counselor, and he built this. And I teach this in my addiction classes. So if we kind of take a look around, and we'll see at the very top of the screen in the process of chemical addictions, we'll see that word codependency. I'm going to talk to you a little bit about that. Of course, alcohol, heroin, crystal meth, work, porn, sex, some SMI, that's serious mental illness behaviors. I've had patients that came in that were on psych meds. I said, "Why are you on a psych med? There's nothing wrong with you." She said, "Well, if I'm not on psych meds, I can't get Social Security." Insane. Cocaine, video games, domestic violence, TV. Sometimes religion plays a game, gambling, marijuana, food, other drugs. And with the other drugs, like antidepressants and stuff, you can't tell me that there are antidepressants that mirror the chemical reactions that, say, meth and Ritalin. We talk about Ritalin, Adderall. We'll talk about those. Um, they have a problem. One of the major problems is to me is, and we'll talk a little bit more about that in codependency, but this sort of self-belief, perception of self, and it drives us into wanting to block that negative perception of self. So we'll pick something in this circle here, so that we can kind of defeat that negative feeling, but we can never really feel joy, and we can never really, but we block that sense of sadness or of great grief or whatever. Um, Many people on antidepressants, they don't want to talk about it. They have this guilt, shame. Yeah, people criticize them, for being on an antidepressant and anxiety and so forth. So it's like almost a secret. And then they block things out, then they start isolating, then they get more depressed. Or one of the things that does happen is they think a relationship is going to fix it, whether man or woman or whatever, and they don't pick the right people for that relationship. Almost always they pick somebody as sick as they are, and that stresses them out. Almost all these people at some level or the other in relationships going to suffer from some level of post-traumatic stress disorder. Um, then when they try to leave that process, there's little triggers that happen. They get stressed out, they flood out, they go back to the psychiatrist, go back to the doctor, get put on more medications. They get frustrated, they get angry, they get bitter, they get depressed, so forth. They have a higher problem with social skills. We know that they'll have a higher issue with employment, relationships, decision making, so forth and so on. If we go back over, because almost every on the left side of the page, we'll see that everybody really desires a healthy relationship, self-worth, joy, fun, self-discipline, spiritual growth, that sense of connection to life. Spire, the Latin word, to breathe. Um, but they're emotionally void. So they develop these personas, and they'll come into your office and say, nothing's really wrong with me. I'm just on these antidepressants. Well, that's true sometimes. I got put it on it for this reason or that reason. Those are generally the easiest people to treat as far as the drug goes, but we still need to take a look at some serious counseling. And then every doctor that's licensed, you're licensed to counsel, but we're not there to sell them our spiritual belief. We're there to ask them if they have one or where they're at emotionally and so forth. Cover a little bit of that here in a little bit. But the primary thing down here in this codependency on the left-hand side, we have the caretaker, the rescuer, the pleaser, the helpless victim, the intimidator, the tap dancer, the martyr, the nice guy. I'm not going to go into depth. That's a whole hour lecture, but I will say when we look at codependency, what we're really seeing is the need for validation. And the caretaker, sometimes they'll create the problem so they can fix the problem. Oh, you fix the problem. We get validated. Uh, let's go to the helpless victim because I've had more than one of those, believe me, where they come in and I don't care what you do, it doesn't work. They'll get angry at you, they'll curse you, and then next thing they'll say they love you because they don't want to lose that connection to you. But their validation is for somebody to pay attention to them. I haven't got this as a case study, but I will tell you a little story. I had a 53-year-old woman. I was pretty early in the game, probably 2001. She had 2 PhDs. She taught at 2 colleges. She came in to me because she had these headaches. And when I was doing the exam, and the story was she created the headache started when she was about 17, and she'd been in some kind of automobile wreck, and she'd had all the MRIs, CAT scans over the years, and nothing was abnormal. And when I was doing the physical exam, I checked her turgor on her skin, and it just stayed tinted up. She was terribly dehydrated. I said, "Don't you understand? It's you're dehydrated. Aren't you drinking water?" So I drink a little bit. So she agreed to let me do a rehydration IV on her. And so we made an appointment for the next week. And I didn't hear from her. She didn't come in. I called her and said, why didn't you come in? She said, that night I went home, I had the worst headache ever, but for the next 3 or 4 days, I had no headache at all. Now we're talking about a lady that complained about daily headaches. I said, well, why didn't you come back in? She said, well, I was thinking about it. I don't know how bad I want to get rid of this headache. I was shocked. I thought, why wouldn't you want to get rid of a headache? So I had to sit back down. I looked at the chart. I looked at the chair she was sitting in. I put her back there. She was sitting like a small, fearful girl with her arms crossed and her legs crossed and kind of bent over, like protecting herself. Um, and the only thing I could logically come up with is I looked at her history form again. She was a single child. We'd had that discussion. Both her parents were well educated. And then in my mind, I could see her tugging at her father's coat sleeve. Hey, I'm down here. Tugging at her mother's skirt. Hey, I'm down here. But she got this headache. Everybody doted on her. Everybody validated her existence, and she couldn't afford to get rid of it. So once again, when we start working with people, really, we want to make sure that where they're at on that plane, if they're looking for some sense of validation or whatever, or if that sense of lack of validation is creating some of that depression or anxiety. The human being is the only animal that actually will pound their head into a brick wall, thinking somehow, sooner or later, that brick wall is going to change. Every other animal, a cockroach in the kitchen runs under the stove, a deer runs over the hill to escape from you, gets stress relief. And so we live in a time, in a place where it's not a healthy environment for a lot of these people, and they're not getting this stress relief, and they're just wore out, they're not sleeping, and so forth and so on. So history, try to figure out what the heck's going on with that. All right. And, so patients can be addicted to almost anything, but it's always going to be something that makes them feel better. And that's always going to be around dopamine. The reward for addictive behavior is dopamine, whether it's chemically induced or action induced, so forth and so on. We don't see the same withdrawals or detox problems with serotonin drugs like psychedelics, but I will say this. We're going to see a really jump in treating people with this high THC marijuana. Ayahuasca is another big thing that's coming up. And I've treated several people coming off ayahuasca, paranoid. There are people on the razor's edge. I had an 18-year-old girl that went over the edge with wax, which is about 90% THC, and they smoke it. Ended up in a psych hospital, ended up in treatment. And when I finally, and she was in IOP or individual outpatient treatment, and she still had bad dreams and so forth and so on. And I treated her same protocols. Yeah, she's back, boy. And her psychiatrist, of course, she said, you're 18, but when you're 25, you can probably smoke marijuana again. I said, you're out of your mind to even go there. Some people are on that razor's edge. They can't do this. You take something like ayahuasca or the psychedelics, it does push some people over the edge. We have got them back, but who says they will come back, And then some common psychotropics, and we've said that before, addictive properties, amphetamines, Adderall, Wellbutrin. If we really look at some of the SNRIs and the SSRIs, not so much about the SSRIs, but the SNRIs, the selective norepinephrine reuptake inhibitors, that's some of the same properties as methamphetamine, amphetamines, and so forth and so on. And so people can, and we've had them. We have a case study coming up where we detox somebody off at 1,200 milligrams of Wellbutrin. And so, all of you are going to treat addiction eventually, whether that's your plan or not. Are you sure what you're treating? And so that's kind of the purpose behind this first lecture, just to kind of sit back and reevaluate and hopefully expand your ability to kind of assess and to take in that whole person rather than just a piece of that person. Female, mid-40s, started treating her in 2001, still treat her. Detoxed off cocaine and meth. She's got some serious psych issues. She's still on bipolar, she's not schizophrenic, but certainly schizoaffective probably. About a year into treating her off all street drugs, but was put on Wellbutrin for depression. About every couple of months comes up short on the medication. The old story, lost a dog, ate it, etc. Challenged her and found out she's doing about 1,200 milligrams per day of instant release Wellbutrin, but she's getting it from several different doctors. And Wellbutrin is a dopamine, norepinephrine, a weak serotonin reuptake inhibitor, much the same action as amphetamines. So all depressants have some connection to dopamine, some inhibitory, some stimulatory. And so basically when we start talking about how can we help motivate that patient, it's not our job to tell them to get off antidepressants or psych meds. I mean, I just don't do that. But when they come in and ask me, is it possible? Can you help me? Then I'm there for them. So I think one of the things in motivational interviewing, if you haven't had any classes on that, that's another hour-and-a-half lecture. Don't be enchanted by the process themselves. There's a temptation to become fascinated with the strategies and their influence. When power becomes a focus in itself, energy channeled into weaponry, influence into control, investment into greed, and healing into self-aggrandizement, our concern ought not to be with our own power, but with our clients. So that's my rule. The patient comes first, the clinic comes second, the doctor comes third. Take care of the patient takes care of the clinic, and the clinic takes care of the doctor. So I will tell you, and I don't know if it's my own experience or whatever, but when I was first talking, and man, make me feel good when people would get it and they'd get better and they'd do their healing and they'd be smiling every day. Excuse me. Then I made that fatal error. I patted myself on the back. I swear the next 10, nothing worked on. We're not healers, we're facilitators. That's the way I see myself. I mean, maybe there's some healers out there. I don't know. Not going to rain on your parade, but I have some knowledge, and we paid for that knowledge, and we gained a lot of knowledge when we were med students. We were med students, but out here we learned how to put the pieces together, and that's what I had to learn that first year too. They taught us all that metabolic pathways and stuff, and then finally you figured out nothing works in a vacuum. When I affect one system, I affect everything else. And so then the three crucial conditions of a physician or a therapist to elicit change. So they're going to come in with a lot of fear, a lot of questions, so forth and so on. Accurate empathy, which is the most important. Now you understand empathy says, okay, I understand what you're saying. I share that with you. I've had that experience in my life, but it's not to be confused with identification with the client or sharing the past experiences. It involves reflective listening that clarifies and amplifies the client's own experience and meaning without imposing the doctor's own material. So I've had those things where I'm listening to the case, and I don't write when I'm taking a case, and I don't do EHRs. I write my charts. Where I might say, excuse me, let me interrupt you for just half a second and ask you a question. Sure, okay. Then I will say, this is what I heard you say. Correct me if I'm wrong. But I'm going to ask you a few questions. I only want a yes or no answer. I might not be the man for the job. And, it might be a trauma issue or so forth, physical, sexual, whatever. Because I need to know, I'm not a trauma therapist, okay? I need to know at the deepest level before I take them off these medications where I need to send these people uh, as an adjunct therapy while I'm doing the work that we need to do. And in that reflective listening, has been shown to improve client outcomes. Why? Because they build that system of trust and that non-possessive warmth and genuineness of the doctor. And that's so important when we're working with these people. Then they get really connected to you. Then it becomes a much, much simple process. Lab work, we're going to cover a lot of that in, I don't know, third lecture, I think, can convince a patient accept help. Put the pen down, turn around to the computer, face the patient, to hear more with your eyes and sometimes with your ears. And you'll probably hear me say that, a couple dozen times more. Just open the lines to communication. Once again, the patient needs to be heard. When they understand they are being heard, man, I'm telling you, you got a patient for life. I mean, that's the way it is. Um, and what doesn't work, confrontation, coercive stuff, attack therapy. All patients have some level of defense mechanisms generally do not do well when exposed to confrontation persuasion. So we make suggestions. So I just say, I'm going to make a suggestion to you. I'm not telling you to do it. But I can tell you, one of the things that will come up, I tried this, I tried that, it didn't work. I said, everything that we do to change requires work, whether you're in Alcoholics Anonymous or in counseling or whatever, because religion's not the answer, counseling's not the answer, AA is not the answer. These are the tools that help you see the truth of self. You may not like it, but at least you know what you need to change with support that surrounds you and your brothers and sisters in recovery or whatever. They'll go through denial, rationalization, regression, projects of blame for their condition, and so forth. Interesting enough, and research shows that coercive strategies do not arise from Alcoholics Anonymous or any other psychological research. Now, I will say this, I've been an AA guy for almost 40 years because I've been in recovery almost 40 years. And there are some people in there, just like there's counselors out there, just like there's bishops and priests or whatever that are coercive. But generally speaking, these are programs and suggestions. We suggest you do this. We suggest you do that. We're not the healer. I'm sorry I wrote that. I said, maybe some of you are healers. I don't know. But I'll tell you this, we're all facilitators. The patient needs to take personal responsibility for the journey into recovery. I'll be there for them. They have my phone number. They can text me anytime. Well, I pull my hearing aids out about 9. I put them back in about 5 in the morning. So I just tell them, you're just out of luck. And so there's always this wheel of change and stages that they go through, whether it's an antidepressant, anxiety, whatever. Detox, first of all, they spend a lot of time in this pre-contemplation stage because they're thinking this isn't working, or I don't want to be here, or it's like a big secret. They think there's something inherently wrong with themselves, and they don't want to really talk to the PCP might not have put them on it, so they're not always truthful with their PCP. But through health screening process, and so basically, it's like, well, it's not working. The kind of thing, well, I quit, but I had to go back, and then they try to do it by themselves, and they get stuck in this pause. But believe me, pause can be much longer than this post-acute withdrawal syndrome can be much longer than something like methamphetamine or opiates or so forth and so on. We know that people will spontaneously quit and get through it. I've talked to a lot of them. And there's people that just can't do it. Because what happens most of the time is when they're trying to do it themselves, they say, okay, this is really truly what's wrong with me, and this is why I'm on the med, when in fact, they need some kind of treatment to bring neurochemistry and biochemistry back into balance. Then they'll, contemplate it. They're ambivalent because there's fear involved. They're aware of the problem with the drug or so forth, but vacillates between change and rejection treatment. And, I've had people come in this office and say, I'm on Prozac. I said, well, how's that working for you? And they said, it's the best thing that ever happened to me. And I said, God bless you, keep taking it, because not my job to say Prozac is an evil thing. I'm sure out there it's harmed some people, but it's out there, it might be efficient for some people. We don't know that balance between biochemistry and genetics and so forth. Tip the balance, saying, well, is it working? And how well is it working? And how many antidepressants have you been on? Because I've had people come in here, I've been on 20 different drugs to treat depression. And invoke reasons for change and risk of not changing, but also that balance point where you say, you know what, I'm willing to work with you, and we're going to go through this process, slow, detox and step down and so forth. At any one time, if you want to go back on the meds, you can always go back on the meds. I'm not here to judge you. I'm here to help you. And then a determination, they need to change, or they have this great desire to change and generally start talking about what they can do to change. So your role basically help the patient determine the best course of action and seeking that change through the safest way possible. Well, they go into action, engage in particular actions and treatments and so forth, intend to bring about change. It does not guarantee change will be maintained. So much in there in that body, mind, spirit, physiologically, emotionally, and so forth. But I will tell you this, when we start doing nutritional medicine, especially when we're doing detox off of almost any med, the first thing we're doing is we're feeding back into the system what the system needs to bring itself back into some kind of balance. There's a physical part of the body and a physical part of the brain. So in reality, when I'm start working with people, I'm working on the physical part of the brain to bring it back into balance, so the emotional part of the brain has something to work with that has some level of consistency and balance to it. And generally, you're talking 3 to 6 weeks. And that once we get there and we resolve some of these other issues psychologically or whatever, and we'll take and help that patient. And then once again, communication. And there's a lot of doctors, even my students would say, you can't give me your phone number. And I said, yeah, I can give you my phone number. The worst thing in the world is if the patient feels abandoned, and then will abandon you, and then it'll go back to whatever insanity they're on. Maintenance, which can lead to permanent exit. And so one of the things we find out in our treatment protocol is genetically, not everybody's the same. I think we all agree with that. And there can be a kink in the program, in the computer, that produces a weak enzyme. I'm going to cover more of that in the future. How do we, through just general chemistry and biochemistry, and let's say we have a gene that creates a weak enzyme. Just chemically, how do we overcome a weak enzyme? Um, Increase the substrate, maybe 5-HTP for serotonin, and maybe might be 120 milligrams twice a day, but we never treat one-sided either. Then we increase the coenzymes. So the coenzymes of vitamins and minerals are basically the energy, the electricity that runs the system. I can push a weak enzyme forward. I have a number of patients that will be on our amino acid protocol for the rest of their lives that have been functional and had been on antidepressants before, but they never liked it. 3 PhDs out at Arizona State, well, took them off Ritalin. They're on amino acid protocols for the rest of their lives, but we got them off Ritalin, and the resolution was a combination of amino acids, which is the protocols you're going to learn, and then just help the client identify new strategies to prevent relapse. Like, okay, healthy diet makes sense, lots of water, exercise, journaling, so many things that can be done on the outside, acupuncture, homeopathy, and all this kind of stuff that we do. And we can identify and what works for each individual patient. Maybe the same thing won't work for the next patient, but there's always something that we can get them energized into to avoid this relapse. Relapse most commonly occurs in some other life crisis, lady that we took off of Effexor and Klonopin, doing really good. Went to a Heal Your Child workshop in California where they had her sign a document, hey, if you go home and commit suicide, we're not responsible. Got off the airplane, and before I knew it, she was back on Effexor and Klonopin. And we've been working with her recently to help her. She's going to be one of those long cases where we do things slowly. Help the patient renew the process of contemplation, determination, and action without getting stuck or demoralized, because we're all demoralized. And then, of course, ethical decision making. There's a process that I go through, not on a daily basis, but pretty much 2 or 3 times a week, where I sit back and I take a look at where I'm at in this thing. And I ask myself some simple questions. Am I doing things for the right reason? Am I practicing honesty and integrity in my life? Are my selfish actions hurting other people? And just take a kind of a daily inventory because it's important. I tell a lot of people this. If we're going to work with these people, we have some groundedness in our own spiritual journey. We have some knowledge to give and some things to help people. But if you don't feed yourself, you have nothing to feed anybody else. So we all have to be healthy, not just physically, emotionally, but spiritually and grounded. We can't get caught up in all this stupid stuff going on in the world today. We have a job. There's nobody in this audience tonight that doesn't have a good heart, that doesn't want people to get better. I've been in that place, codependency, where I heard they relapse and then I follow them around and try to find them back out in the streets of Phoenix, Arizona, where they're shooting up drugs. And they finally figured out they know where I'm at. If they wanted me, they'd come see me. It kills me sometimes when some of them go back out and die on the streets, but it's not my responsibility. So ethical behavior is essential not just for us, but for cultural norms and so forth. And to guide us into also limit-free thinking by framing truth as our own perspective, like we have all the knowledge and they don't. Sometimes these patients will be your greatest teachers. I laugh, but it's funny, it's true. Ethical dilemmas are rarely the same, yet we often rely on familiar paradigms, black and white thinking, and so forth. Oversimplifying issues distorts outcome, while overcomplicating them wastes time and obscures clarity. Critical issue is not which paradigm we use, but how and why we choose it. And that's so much about the patient and history and so forth and so on. And then, of course, the Nietzsche statement, convictions are more dangerous enemies of truth than lies. Nothing worse than condemnation before investigation. And then certain ethical rules transcend culture. It doesn't matter. It can be any race, any culture, but ethics is ethics. Honest self-reflection, we talked about that, and veracity, tempered by compassion, integrity, and discernment are essential. But every once in a while, even us doctors need to sit back and find that place of silence and solitude and quietness and stillness, just to let ourselves come back into balance. Oh, I say quietness, solitude, are the food for the soul is food is there is food for the body. Truth often exists as shades of gray. Once again, get back. Are we getting the truth? Required openness to multiple perspectives, ethical principles such as autonomy, justice, and so forth emerge from these rules. By grounding decisions in self-awareness and ethical principles, complex dilemmas become clearer and more manageable. So these are kind of the things that I've had to learn over this 25 years because we walk out of, not that we don't have it, but it's not that we don't have it when we start, but we refine it because the patients become our teachers in many ways. The genetics is your computer, born with it. Doesn't operate randomly. You need input to get something to happen or come out of it. And so when we put these drugs or whatever, it's kind of like a Ritalin kid, it's like ADHD. We put a bunch of sugar and dyes into them, and the computer says, okay, I'm programmed right from the start, but I have to accommodate this change in diet. And we know for a fact that if we can take some ADHD kid, most of them off of sugars and dyes and stuff, that they improve rapidly. And then you have to remember that 70% of medical issues can be resolved through the placebo effect. That's a well-known fact. And so when people come in and they're on these antidepressants, they have no other medications, and there'll be a large portion of them. They might have been put on another medication, like we said before, like Zoloft can create anxiety, and some lady got put on an Xanax and so forth. Got to peel the onion there, it's kind of like homeopathy. What did they get on first? What did they get on last? Generally, we do the last one first. It's the other 30% we work with that have issues, some minor, some major. A properly functioning system, as long as we're eating a healthy diet, exercise, and drinking plenty of healthy fluids, then operationally we should be good, or at least adequately function. Now we'll say this. There isn't a human being out there, including me or Dr. Dan, that's not bipolar by nature. We have our ups, we have our downs. This is bipolarness. It's not whether we're bipolar, it's whether we're functional in our bipolarness. We've had quite a few successes in treating bipolar people that have come in off meds or have never even started meds, Ritalin, ADHD, so forth and so on. And you will get large portions of your patients that have resist antidepressants, thank God, that you can treat with these protocols. We're going to have case study after case study of these kinds of people that, I've had people come in and say, I've been sober and clean off meth for 25 years. I think I've been depressed every day, and start them on the protocols. And the guy called me in a week and he says, how fast is it supposed to work? And I said, it works really quickly. Basically, it's food going in. And he said, well, I did the evening dose, and the next day I was a completely different person. He continues to do the protocols because it's what works for him. We live in a time where processed food does not have the same nutritional value. We're all familiar with that. 56 years ago now, I'm 76 years old. I grew up on ranches and farms. We always had 2 gardens, orchard. All summer long, it was nothing but canning. Every once in a while, escape into the canyon, go fishing with the beavers. And And so we didn't have any dyes, and so well, we had Kool-Aid. I forgot about that. And we were poor, man. I'm telling you, you go work in the fields, and there's a nickel for Kool-Aid, and then a cup of sugar, and strawberry sandwiches, and so forth. But 40% of our children, 70% of our aging adults can fit the definition of obesity. We have major issues. And part of that major issue is, do you think any child or any adult really, perceives self as being worthwhile? That's why we see this uptake, not just because we're obese, but because we're not feeding the body in a way to keep our biochemistry and neurochemistry in balance. We have no sense of purpose in life, no meaning in life. Some 13 to 70% of our US population on antidepressants. What's that? 30, 40 million people. It's unbelievable. We're the most drugged out country in the world. Why? We're the most successful country in the world. So, asterisk there. And all this affects digestion and gut motility. And I'm going to tell you something. Next lecture we have is, which will be next week. We're going to go into these drugs and how they actually create changes in the body. Antidepressants, benzos have many deleterious actions in the human system. And antidepressants and benzos share some of these negative effects, but they're still different animals. And I always said that the benzodiazepines are the drugs from hell. It takes longer. The effects are more profound. We can get people off antidepressants. I'm telling you, 80, 85, 90% of the people we can do that. There's going to be some, not completely maybe, but we have cases where they're on a low dose antidepressant and amino acid formulas, and that works for them. So there are some of those cases. They're low percentage cases, less than 5%. GI tract is a very controlled organ. Antidepressants negatively affect the gut-brain axis. We're going to be talking about gut motility, digestion, and so forth. Benzos and antidepressants are well known to cause dysbiosis and some negative cardio effects. What's really interesting is we want to know what is the percentage of people that have dysbiosis that in a minor way versus a major way, and the labs that can be involved in that. And we're going to talk about some of those labs and the cost of some of those labs. But I'm going to tell you something. Once again, think about the whole purpose of starting something is to go to the simplest place possible without running some labs that people have to pay for and so forth. Things like CBC with the DIF and hormone panels and stuff without question, thyroid and so forth. And how many times have we treated these symptoms without knowledge or knowing the patient is on these medications, and that the majority of the symptoms may be caused directly by the action of these medications on the system as a whole. Commonly happens, the patient is put on other medications to resolve these issues, which often makes this case more complex. All antidepressant benzos go through cytochrome P450. That's not exactly true. There are some that actually basically go through the kidneys, a few of them. Pathways that go through is known as a substrate, but most also active. A lot of them act as inhibitors, blocking the breakdown of other drugs. Some enhancers, they enhance the breakdown of drugs or they don't work. Wise doctor that understands this. We talked a little bit about this patient on Cymbalta for a rough time in her life, and she'd been on it before. We talked a little bit at the beginning of the lecture. Started having hypertension, common with SNRIs, panic attacks. Turns out she started drinking large quantities of grapefruit juice. It was a strong inhibitor of many drugs. She's basically overdosing on Cymbalta, especially any drug that goes through 3A4, which is a lot of your longer acting benzos also. Take home message is to know what you're treating, get a complete drug and dietary history before you and the patient can make a healthy, informed decision on cessation of the drug in question. So the real take home message really for this, and I don't know where we're at with this.
We're right at 7.
Right on time.
Yeah.
History. And I think, sometimes when I start putting this lecture series together, I kind of thought, the old saying is kind of like the preacher preaching to the choir. But I had to understand, and I'm going to teach it like I always teach it every class I've ever taught. I'm going to come back to the very beginning. It may just be a review for you, and that's good too, to kind of pull some pieces together. Um, but it's definitely 25 years of trying to figure out some of these. And I think, especially when I started working with alcohol, drugs, and opiate detox, methadone detox, and so forth and so on, what makes anybody different, whether it's an antidepressant or benzodiazepine? Why do we have such difficulty in detoxing people off these medications? And I can tell you, psych meds are almost always, with the exception of Ritalin and Adderall, are all step downs. And you can cold turkey somebody off meth. You can cold turkey somebody off cocaine. You can safely cold turkey somebody off alcohol, uh, even methadone. And there's certain protocols that I use for that. And but you can't cold turkey off somebody off benzos or antidepressants. It just doesn't work. All right. Well, thank you so much for being here. And if you got questions, ring them up.
Any questions? Anyone?
Next week, we're going to talk a lot about the actions of these antidepressants and benzodiazepines on the system. We'll talk a lot about dysbiosis. We'll talk a lot about, how they're detoxed out of the body, how they're metabolized out of the body, half-lives, and so forth. Because that's a lot of that information basically is going to determine how long we want to take to get somebody off of that antidepressant or the benzo.
Okay. Does everyone have their PowerPoints from today? You just say yes in the chat or
Yes.
okay.
Okay.
I'm gonna paste the link in the chat right now if some people don't have it. So I just put it there if you want. Okay, well, if anyone doesn't have any questions, we're going to end the session for tonight. Looks
Thank
like
you.
thank you, guys. We will see you next week.
We got a word. Thank you, Lynn.
All right. You'll have a good night.
All right.